What is up, everyone? How are we doing? Welcome back to another episode of Dental Student Vibes Podcast. My name is Seth Kalish. I'm here today with Anthony Wallish and Matt Havis. And today, first day back, we had Perio this morning, and we had the infamous, the diabolical Stab Lab, aka Injection Lab. So, me and Anthony had that today. Matt, you've got it when? You've got it in a couple weeks?
The 30th.
The 30th.
So,
yeah, we got it out of the way. By the way, happy 2020. Happy new decade to all followers and listeners out there. It's the 2nd of January, already in school. It's just the grind, you know?
It's the grind. We are back at it again. So let's talk about Stab Lab. So basically, Stab Lab is our first experience doing injections, and we do the injections on each other. And we just use, it was lidocaine with 1/100,000 epinephrine. And honestly, it was not that bad. It was more the anxiety going into it that you think you're going to get injured. That's honestly the worst part, but it wasn't that bad. And you think like the needle stick, they say that the needle stick isn't what hurts, the expression of the anesthesia into the tissue is what hurts. That's 100%
the buildup of the
true.
pressure, right?
Yeah, that's 100% true. And I think really, you know, when we first started doing it, I was not sure really what I was doing, but at the very end of the lab today, it felt great, you know?
Absolutely. So we did them in groups of 3 or 4 today. Seth and I were in different groups. So my group of 3, I was the one giving the injections first. So that was a little... I felt like it calmed my nerves because it allowed me to do it, but it was also nerve-wracking because I was the first one going. But I did the injections, and then I gave I was given the injections after by one of my classmates. Still a little numb from it.
Yeah.
In my lip.
Yeah.
So yeah, basically half of our mouth got taken out by these multiple injections, and then on the third rotation, you just assist. So it's just kind of like you go in order, and you go through a bunch of these nerve blocks and infiltrations, and it's really cool, honestly.
Yeah. So what were the
techniques
today?
So we did. Each group had different teachers, so I'm sure to each his own. But so the way we did it was we did an inferior alveolar nerve block along with a mental block in the beginning. Then we ran towards the long buccal, and then we did the PSA and the MSA up on the maxillary, and then we did the infamous greater palatine nerve block, which is considered the one that hurts the most. It's kind of like on the roof of your mouth, on the hard palate. I actually had to get 2 injections for that one. Which, I got one from my buddy Jeremy, then one from the professor. He's like, we got to do one more. So that felt good.
Yeah.
I'm sorry, Min gave me injection. I gave the injections to Jeremy.
Okay.
And Jeremy said I didn't even hurt him when I did the greater palatine, so I was hyped about that.
Yeah. I think one of the most difficult parts is really like getting the confidence to put the needle all the way through. Because at first when you, like, we use the long for the long needle for the inferior alveolar nerve block, and you only want to put it in like 3, 4, 5 millimeters, but you got to put it in like, you know, 2/3, 3/4.
Yeah, so some of them you can kind of put in just a couple millimeters into the vestibule, like when you're doing the like the long buccal and stuff like that. But like for the inferior alveolar nerve block, you gotta go deep. Like you gotta touch bone. Dr. Youngblow was saying like 20 millimeters or something. That could be.
Yeah.
It's deep, and your first time doing it, you don't feel comfortable because
right.
You're so he wanted us to be like aggressive with it. He wanted us to have confidence, and meanwhile we're like going like so slow. And
is it in?
It's just it's your first time doing it. And he was very understanding. He's like, you just gotta go through it a couple times, but it's really not as bad as I thought it was gonna be.
Well, we switched up the technique because we started out. I was the first one to inject. And so I just started out with the IAMB, and that's the most difficult one, right?
Yeah.
Honestly, you should have just started with the PSA, MSA, or the greater palatine, just because you're using the short needle, right? And I think there's probably a lot less room for error, you know. So probably best to start out with those. Start with the maxillary, and then I hear that like a lot of people they just do the infiltrations and that's it. For maxillary.
Oh, wow.
Yeah.
Some people don't do the blocks because they're. It wasn't that painful. I mean, it was just a little pressure buildup, but it went away within seconds. But it's one of those stigmas in the field that everyone doesn't like the greater palatine, so I can understand why people would do it that way.
Either of you guys cry?
Well, we didn't do the incisive for Raymond. So
No.
No, we
man.
didn't do that.
yeah, thank God.
No,
Okay.
that's definitely not enjoyable.
Be honest, did anyone cry? in
No.
your groups?
No, I didn't
No?
cry, but when they were like poking around with the other end of the cotton swab, the wooden end, and they're trying to they're pressing on my
trying
palate,
to find
and they're going
the
like
depression.
past the vibrating line, I almost gagged.
no.
It was
He
bad.
said a couple people probably out of the 100 that go throughout the next couple weeks, said a couple people probably might get dizzy or lose
Be alert.
he said you just have to sit down, but you're gonna be fine. But honestly, I was laughing when I got the injection
Really?
because it felt like my lip was on the floor. It did, but it was completely in the right place, and it was just funny because I couldn't really speak properly.
Sounds like they really got you good though.
I think Men gave me a little bit, so that was pretty cool. Shout out Men.
Yeah.
So the purpose today, the reason why we started so early on doing doing stab lab in spring of D2 year, even though we're not in clinic yet, is they really want us to start getting comfortable with handling the needle and the syringe, so that once we're actually in clinic in 5 months, we'll be able to be more confident. But even then, when we go in, we're still going to practice it a couple more times. Our preceptor is going to do it with us once again, and then the same professors that were with us today, I think, will do it with us a third time, and then we'll do it eventually on patients. And the third years now, I was speaking to a few of them before I walked in today. They said it was super easy, and they seemed super nonchalant about it. But I'm sure when they first started doing it, it was scary for them too. It's just one of those things, it's it's just another landmark. It's another stepping stone,
Right, but this is something we're gonna do every single day.
Every day. Dr. Youngblood was saying you're going to do 75,000 of these things too.
Oh,
you do them with almost any procedure,
That's true.
So it's important, and he was trying to emphasize how important knowing where you are and knowing what you're doing is, because if you can help keep your patient out of pain and you can kind of take away that anxiety, through the
What's that called? That anxiety reduction protocol?
Yeah,
Vocal?
exactly.
Was it vocal anxiety reduction?
No, this one was using
No, I'm saying, do you remember what it was called when you try and soothe your patient with your voice?
Oh yeah, I don't
What's
remember
that called?
the name
I
of
think it's
it,
just
dude,
called.
But yeah, there's so many steps towards it, the anxiolysis procedures
Yeah.
and stuff like that. But he just basically was telling us today, just make sure that you focus on this and you get good at this, so that your patients will be calmer and that they won't experience pain. Because if they don't experience pain, they'll enjoy going to you more, and
True.
they'll refer you and recommend you to their
Build
friends.
trust.
Which is what you want. Of course, you don't want your patients in pain while you're in the dental chair. You want them to be able to walk into your office, feel good, and sit there knowing that everything's going to be taken care of. So he tried to. He didn't stress knowing it today, and obviously it's hard, but he wanted us to know that by the time we're third, fourth years, we should be able to do this pretty well.
It's it's kind of a wet run because we actually used it, but at least you're exposed to it now.
Absolutely.
Early.
And then I heard that we also do it our third year.
Yes.
Cool.
We're going to do it when we get into
Before
clinic.
we start.
Our preceptors will have us do it, and then I think they come in again, he even said.
Oh wow.
Which is good, though.
And then in a couple weeks we also do nitrous.
Yeah, so I start nitrous, Seth and I again. I don't know if we'll be in the same group this time, but we're in the same they separate people into certain time sections. So we have it in 2 weeks, which I'm kind of excited for because I heard nitrous is pretty cool.
Yeah.
Never had it, so I'm looking forward to seeing.
Yeah.
I've had lidocaine.
Okay, so how about some tips and tricks for students out there who are going to be doing local anesthesia soon?
Okay, so I think the keys that we were talking about today was needle angulation is a must on certain blocks, like the I and B. You want it to be contralateral. When you go in from the other side of the mouth, you want it to be crossing the second premolar. He said that was super important. Certain blocks, you kind of just go straight in, but angulation was super important. You need to know when to aspirate. When you go in, you should be aspirating to make sure there's no blood in the carpule. If there's blood in that, you have to pull it out. You have to change it, stuff like that. Topical was preached. I know not everyone uses topical, but I think topical is an important thing, at least for controlling maybe anxiety for a patient that might not handle it as well, and making sure that you keep the surface dry, and just knowing your anatomic landmarks. It's not as hard as it seems once you do it, but it's intimidating, definitely, before you actually get in there and start working on your classmates.
This is one of the first invasive things we do in somebody else's mouth.
Well,
when you
yeah.
think about it, so
Because the most invasive we've done before that is a cleaning. or anything you did
or
in
denture
assisting.
impressions.
Yeah, so this is like you're actually like breaking through like the mucosa and like you're going into like.
Okay, I got 3 tips for you.
Go for it.
Specific. All right. First of all, when you're doing the local anesthesia, that's, the topical anesthesia. Take a cotton swab, and you take the topical and you place it directly onto the tissue. Right. The tip is to use the 2x2 gauze and get it super, super dry, the tissue, so that it doesn't get washed away by saliva. So that's number 1. And then when you take that 2x2, you hold it up there with the cotton swab against the tissue, and you can like let that sit for a little bit. Number 2, when you're doing the nasopalatine and greater palatine blocks, or just any of the blocks, honestly, or anything, you can use the back of your mirror, the mirror holder.
Anything that's like a solid surface, or like the sticks that we use today.
Or you can use the other end of the cotton swab, the wooden part, which has a smaller diameter than the mirror holder. And you use that to place pressure against the tissue, and then you place the syringe, the needle, directly into the same spot that, like, you'll see the tissue that's being blanched by the pressure, and you place the needle in as you're removing the pressure with the stick. And that's because, when you get, let's say you get hit in the arm by a baseball or something, what do? You rub it with your hand, right? That's because the pressure sensation turns off the nociception, which is pain reception.
Yep.
It turns it off and inhibits it.
Wow.
So that's one of the tips.
We learned that over the summer. I forget in what class. I was thinking about this a couple days ago, actually.
Yeah. And then the third one, this isn't a tip, but this is something that's common on the internet and that we found, and then we asked about it, and apparently it's incorrect. So the tip is that you might see on the internet is to use a cotton swab, spray the cotton swab with endo ice, which is used for endodontic procedures for testing, and place that endo ice directly on the area that's going to be anesthetized, or where the needle will be inserted. And apparently it works, but it's not good to do because endo ice directly on the tissue damages the tissue. So
I just thought of 2 other things also.
Yeah, go ahead.
So for the IANB, you want to, when you're about to put it back there, you want to shake. Kind of like the same concept with the back of the mirror. It's also to distract the patient a little bit with the pressure. When you're doing the IMD, you want to shake your patient's cheek with your other hand that you're not using to inject with, and you want to shake it like aggressively. When I was doing it, I was just kind of like,
really,
yeah,
because we didn't even do that.
No, he was telling me that's a very good tip. It kind of distracts them, and by the time their mind wanders from their cheek back to the injection, you're pretty much done.
Yeah, that's good.
And then another one is you got to be really careful with, like, when you're done with the needles and, like, making sure you dispose of them properly. He went through that. And
how did he tell you to do that?
So you have to always, like, when you're done with the needle, you know how you have, like, that paper or
the cardboard,
that cardboard piece in between them.
Yes, that holds the cap.
Yes, you put that right back on. Always when you're done, and then you basically will just screw off the needle side from where the top of the cap is, so that your hand's nowhere near the needle. And then when you take that off, the other side of it, not where the cap is, the other side will have a short little needle. You cover that side with the plastic piece that you broke off originally, and you have to dispose of them properly in, like, those red, like, like containers.
It's a sharp spin.
Exactly. And it's really just kind of just thinking about what you're doing at first, and then to guys like them, it's probably, like, second nature. They do it in their sleep. But for us, it's just make sure you know where the needle is at all time. When you have your assistant helping you in the future, make sure, because the assistant, the way we were doing it today was the assistant will hand you the needle, and then they will, when you have it in your hand, they will pull, like, the cardboard side with, like, the tip. They will pull that off, and that will expose the needle.
Yeah, we didn't do that.
That's how he had us do it. I don't know if it's going to be like that in every practice, but just make sure, like, even when you're working, because your eyes are going to be focused on the patient, you're not going to be looking at your assistant. Make sure everyone's out of the way when you go to inject. Like, you don't want to, like, accidentally like injure, like, your assistant or anything like that. So just be really careful with it. It's not a toy. It's very sharp, but it's honestly it's kind of fun, honestly, if you do it the right way.
The way that he had us do it, you can do it 2 ways. So this cardboard thing that Anthony's talking about, it's basically just to prevent you from a needle stick, right? So it's a shield, I guess. It's a square piece of cardboard with a hole in the exact center, and you put the cap of the needle in before you remove the cap from the needle. And then, so let's say you finish your injection, your cardboard is laying on your whatever, your piece of paper, your little tray, and without you, the whole point is like you don't have to use another hand, so you can directly insert the needle into the cap and the cap holder while it's laying on the tray. So that was the first thing. The other thing, if you don't have one of those cap holders, the cardboard piece, he said to hold. Okay, so I'm right-handed. Hold the whole syringe in your left hand, and then hold the cap in your right hand between your index and thumb, and then touch your pinky to your to like the syringe or your hand as like a fulcrum, and put it on like sideways, like very carefully.
Oh, that's interesting. Okay.
Yeah, so it's almost like as if you're drilling, so you've got more stability with where you're moving the cap to.
That's another thing that we were taught today, is that there's a lot of techniques, and he told us my way isn't necessarily the right way. You're going to learn other ways from other people, and you kind of just need to find what you like and mix and match. It's like, when you do a crown prep, we don't always do it in the exact order that we're taught in SimLab. You pick up and pick up little pieces from stuff.
There's an exact opposite way of how we were taught how to do it.
Exactly. So he was very clear on that, which I thought was very comforting, because it doesn't make you feel like you have to do it just this one way.
Now, what you guys were saying about needle sticks, not necessarily for yourself, but for the patient, where as you're inserting into the mouth or whatever, you can nick the tongue or the gingiva on the way in. Mm-hmm. Did you guys have any experience with that?
I did not.
No. Somebody else hit my tongue with the tip of the needle, which didn't feel very good. But
how would you recommend that you fix the problem so you don't needle stick the patient? Because they're not going to like that either.
Are you saying in terms of preventative, or if you do, what do you do after?
How would you make sure you don't do it? As you're inserting,
you need to make sure that the tongue's under control. So if you're doing a mandibular block, on the bottom of the mouth, you want to make sure that the tongue's out of the way. Same thing with maxillary.
How?
You might just have mirror. You can use a mirror, but if you don't have a mirror like we did today, you just tell your patient to move the tongue.
Okay.
Unless they're fighting.
That didn't work at all.
Didn't work for you?
That. No, because when you try and move the tongue, then it causes the muscle to be flexed, and then it goes out of the way, so you can't actually access the spine.
Okay, so that's what we did today, because we didn't have a mirror.
Then? You have your assistant retract?
Right.
While you do that?
With the mirror, but we didn't have
we didn't have mirrors, so we would just say move the tongue, but in an ideal clinical situation, yes, you use a mirror to move the tongue out of the way in that situation.
Okay. And you guys have any issues between people? Anyone have paresthesia or anything like that?
No, everyone was fine.
What everyone worries about, did anyone have any issues?
I can still feel my face. So
my lip is the only spot that's still numb. My cheeks were, numb for an hour, dude.
Okay.
But I'm fine now.
All right, guys. Well, that was Stab Lab today. Matt, I'm looking forward to hearing about yours.
I'm looking
forward. What we're going to do is we'll record right after I get it done.
That's perfect.
Just so you guys can understand.
I'm looking forward to seeing you drool out of the side of your mouth.
We'll record you with, still numb.
Okay.
Yeah. All right, guys. Well, we hope you learned something about Stab Lab, about injection techniques.
Do not try this at home.
Yeah. Do not try this at home. Be sure to hit us up on Instagram. We love all the feedback we've been getting from you guys at dental.student.vibes. Also, check out our book on Amazon, 7 Hacks to Boost Your Dental School Application. Let's see what else we got going. We got a big year this year. Lots of stuff planned.
And for any of the upperclassmen or any new dentists, if you guys want to share any of your Stab Lab stories, if you have any funny ones, anything that went sideways, message us on Instagram at dental.student.vibes, and we will read it out loud to the rest of the group.
That's a good idea. Feel free to share your stories or email us dentalstudentvibes@gmail.com. The classic. All right, guys, take care. Happy New Year, and we'll talk to you soon.
Peace out.